Good day, everyone. I'm Siang from Malaysia. Today, I'd like to present a topic of Paraplegic Toddler with Gibbus Deformity. I have no conflict of interest with regard to this presentation. This is the outline of my presentation. For introduction, tuberculosis spondylitis, also known as Sports disease, is not uncommon. However, its occurrence in pediatric population is somehow rare. Although diagnosis tuberculosis spondylitis in pediatrics is indeed challenging, early diagnosis and prompt treatment can improve the clinical outcome. I'd like to share a case of a 2-year-old boy who pre-morbidly walked independently, presented with prominent upper back deformity and bilateral lower limb paralysis. He had no constitutional symptoms. However, on further history, he had a history of close contact with his aunt, who had prolonged cough, but was unsure of the diagnosis. On examination, there's a gibbous deformity over lower thoracic region with bilateral lower limbs show no movement. Neurological examination revealed paraparesis of bilateral lower limbs, Frankel grade C, with signs of upper motor neuron lesion. For the lab investigations, the total white cell count was 30. The erythrocyte sedimentation rate, ESR, was 53. CRP was also raised, which is 49. Primary tuberculosis workup, such as gastric lavage for AFP staining and MTBG expert, were all negative. For the imaging, we then proceed with MRI whole spine, and it showed T9, T10 tuberculosis spondylitis with Gibbus deformity. The local kyphosis angle we measured was 45 degrees, and it also showed severe spinal canal stenosis with spinal cord compression and nerve root impingement, and large paravertebral collection with extradural extension in thoracic region. He then planned and underwent posterior compression, debridement via T9, T10 costal cystectomy, and body cast application to correct the kyphotic deformity. Adequate debridement and decompression were achieved intraoperatively. The intraoperative acid-fast bacilli resulted positive, and anti-TB therapy was then commenced. Local kyphosis correction to 20 degrees was achieved after casting. Post-operative 1 month during the follow-up, the patient appeared less ill with improved motor power of bilateral lower limbs. For the discussion, tuberculosis is actually common worldwide, not just in Malaysia, with a 3% affecting pediatric population, and there's increasing infection rate over the past few years. Tuberculosis spondylitis is an extrapulmonary manifestation of tuberculosis, which will lead to disability and significant deformity. Lack of awareness by the general population and scar symptoms that present at the onset of disease usually delays the diagnosis. Tuberculosis spondylitis was usually due to hematogenous spread of mycobacterium from the primary focus in lungs or genital urinary tract. The therapeutic goal is to heal the disease with minimal residual deformity without neurological sequelae. Although tuberculosis spondylitis or Sports disease is rare in pediatric population, clinical findings such as thoracic gibbus and neurological deficit should raise the suspicion of tuberculosis spondylitis. Delayed diagnosis and treatment, especially in growing child, may result in devastating and catastrophic complications, such as severe bony destruction, spinal deformity, and paraplegia. These are my references. Thank you.